Welcome to Spine and Body Podcast. This podcast's stated goals are to change how the world treats musculoskeletal pain, to create experts in the treatment of neck, back, and shoulder pain, and to advance the world's understanding of this pain, to inspire researchers, thinkers, and innovators, to empower patients and embolden caretakers. Follow us on this journey and let's learn and grow together. This podcast is brought to you by the Body Guitar Clinic because your body is a finely tuned instrument. Like all finely tuned instruments, it must be properly cared for in order to play the beautiful music it was intended to play. Care for your body and use it correctly, and it will play music that is unique to you, your life's song. This is Sean Wheeler, MD, and let's get your body in tune.
Okay, so welcome to another episode of Spine and Body Podcast. This episode is going to be about myths that people hold that keep them from getting better. Do realize that this is now the first episode with us videotaping, and I'm trying really hard to look at the camera, but it's this weird dynamic where I'm like, it feels uncomfortable that I'm staring at the camera. I feel like I should look away. So I'm getting used to this. You're going to see me look down, look at my notes, but that's it. It's been, I think, 3 years and 5 months since the last time we released an episode. So I'm excited to start doing this again. I think I said last time it's not going to be every week. It's going to be as the as the mood strikes me, and as we find things that are very applicable. So I am releasing a book. It's been 10 years since the last one was released. It was called Uprise, and it was Publisher Weekly's National Book of the Week. It did well, and then last year I was approached by some pretty prominent podcasters to speak. And while that's still in the works, it inspired me to rewrite the book. And with that, some amazing discoveries, or what I say, steps forward in how I propose the spine is stabilized has been in the works, and we're excited to share that. We're discussing a spine wellness center, which is another exciting thing moving forward. But this all started 10 years ago with a guy named Steve Cranford, who lawyer, marketing genius, and became a friend of mine, who would talk about the fact that there were 6 places in the body that had to be stable. And he said, and as I was playing guitar on the back porch with him singing along, neither one of us doing very well, he said, that's like a body guitar. You should name it Body Guitar. And I thought that was a terrible idea. And then he came up with this logo and so many other things that attached to it that won the day. And Steve passed earlier this year unexpectedly from a heart attack, and I miss him. He was a good friend, and he was great at bouncing ideas off of, and he was a good man. But in the meantime, so many things about how we think about the back has transformed into an idea that fits with body guitar. And the book explains this. I think over the next several podcasts, I'll explain this. But today is the welcome back, and it's the first, kickoff. So hopefully we can get right into that. So if you've ever had back pain and not gotten better, you have developed some myths about your back pain, either from your doctor or social media or somewhere. Myths about your diagnosis, about your imaging, including MRI, about your rehab, about whether you're going to have surgery. There's tons of myths that go along with a person getting better or not getting better from back pain. So the first myth is really a previous diagnosis, right? It's people come in with an idea of what their diagnosis is, and they'll come in and it's like they've owned this diagnosis is part of them. They'll say, I have this disc bulge, and this disc bulge is causing my problem, and it's been the like a business card that they've carried with them for years, and they've thoroughly researched it, and it's become part of them in the fact that it's how they explain to people why they're not living up to what they should live up to. And then they come in and see me, and I basically go through, try to make a diagnosis, completely ignoring the business card diagnosis they came in with. And then when I try to explain it to them, all they can hear is what they previously had. So these myths, if they are myths, if you're not better, they very much could be, sometimes are keeping people from getting better, because it's all they've ever been given, and they cling to it too much. So let's go through them a little bit if we can, and you really have to rid yourself of these if any of these are you. So the first is the MRI. The thing to realize about MRIs is that an extraordinary number of people who have no back pain have a disc bulge or spinal stenosis or degenerative disc disease. An extraordinary number of people. There was a study done by Maureen Jensen in 1994 that was in the New England Journal of Medicine, and they took people of all ages and MRI'd them all, and they're in the MRI and doing these MRI studies, none of these people had back pain, and 52% were found to have a disc bulge. 52%, right? And of those 52%, many had disc bulges at several levels, and 1% of people had a disc bulge that was extruded, which means the center has not just bulged out where the bulge is not as far as how wide it is, but an extrusion where it's like a stalk that is bulged out into the canal. And I'm one of those people. So when I was 43, they put in a new MRI machine at one of the places that I worked, and they needed a volunteer. So I go in and I say, okay, I'm gonna show you guys what a perfect 43-year-old back looks like. So I go in and get the MRI, and they call me like a half an hour later, and they're like, you have an extruded disc. It's completely filling the canal. We can't even see the spinal cord. You need to go see a spinal surgeon. And I'm like, yeah, well, I don't really hurt, so thanks, right? They couldn't believe it. They were like, no, we've already made a diagnosis. And I'm like, it doesn't matter. I don't hurt. 1% of people with no back pain have an extruded disc. And I want to be in the 1%. I just don't want to be in that 1%. But is what it is, right? So I'm one of those people, and I've never gotten another MRI because why would I? I don't hurt, right? So the other thing to realize is that, they did a study on 60-year-olds with no back pain. 96% had disc bulge, spinal stenosis, right? There's been study after study that's shown degenerative disc disease is found in people with and without pain. It's not a question of can those things actually cause pain? Can a disc bulge cause pain? Yes. Can a spinal stenosis cause pain? Yes. Does degenerative disc disease cause pain? I would argue no. I know that there's a lot of people that say yes. The studies really back me more than them, but it is what it is. So what happens is that we have MRIs. It's not that they're not right in some cases. It's that they're not a good diagnosis. Really what we need an exam, right? You have to have an exam that shows spinal stenosis and a history. You have to have an exam that shows a disc bulge and a history. And you can't just say, well, I have pain down my legs. Lots of people have pain down their legs. It's not diagnostic unless it fits exactly with the disc bulge. So a lot of times I'll see people and they'll have pain and even pain down their legs, and I'll look for anything else that causes pain. And the reason is because anything else I can treat, and I can do a diagnostic treatment. Like if you have SI pain or hip joint pain, and either one of those is causing a piriformis muscle to spasm, you have pain down the leg. And if I treat that pain down the leg, if I treat that SI or hip joint pain, and you get better, Who cares what your MRI shows? The MRI is not diagnostic. It doesn't help us unless it fits or unless we've ruled other things out. And you say, well, what about an epidural? Well, the problem with an epidural, and this is a second myth, the problem with the epidural is that I put medication into the epidural space. And there are times when I will get a momentary numbness, but not enough to be diagnostic. If I put medication into the epidural space, it takes 2 to 10 days for an epidural to take effect. Guess how long oral steroids take? 2 to 10 days. So, 2 to 10 days, I give you oral steroids and your ankle feels better. Does that mean that your ankle was causing everything? Or your wrist feels better? Or is that a diagnosis? Or is that just those areas were irritated? So I give a person an epidural steroid injection, and that steroid works 2 to 10 days later. That is not diagnostic. So what people have done is they've said, okay, we're going to take a non-diagnostic MRI, and we're then going to do a non-diagnostic epidural, and then based on the results of that, we're going to say, we've proven that your disc is the problem and that you need back surgery. Well, this is not diagnostic. And instead what should happen is that people should say, I'm going through the rest of your exam and I'm going to try to figure out if there's anything else causing it. And if I find anything else, if I can treat that in a diagnostic fashion, well, then that's what I'm going to do. I'm not going to jump in and say, well, the MRI says, or I did an epidural and they got better, because both of those can cause problems. The next myth is that people will say physical exam doesn't help. And the reason why they say this is there was a group of studies that are now referenced by CMS, which is Centers of Medicare Services, right? And Centers of Medicare Services is one of the leading ways or leading groups that sets the course as far as what other people do. And they use 3 studies to say that exam of facets is not helpful. And the first was a set of questions in 2020 sent to a dozen pain societies and veterans hospitals, in which included whether they thought the physical exam was helpful. Now realize this is a group of anesthesiologists and pain doctors who don't really do an exam. So they asked the people who don't do an exam on whether they thought physical exam was helpful. The second was a 2020 Pain Society consensus statement. And in this Pain Society consensus statement, there was a statement that included, quotations, the limitations of these guidelines include a paucity of high quality studies in the majority of aspects of diagnosis and therapy, end quote. Therefore, this means that the Pain Society came forward and said, we don't think physical exam works, but we don't really have enough studies to prove this. This is the second study that Medicare uses to say that exam doesn't work. The third study was a study that involved 17 studies. So it was a review study. It was a review study from 1966 through 2015, where a physical exam was done that showed facet pain, and then they injected these facets. And they didn't go back and say, do the facets still hurt? They asked the patient. Now, this may not be how all 17 studies went, but this is how the authors presented it, and the study's behind a paywall. So they said, of these 17 studies, they then went back and asked whether the person still had back pain. And 25 to 44% said that they still had back pain. Now, the problem, of course, is that when you look at people who've had lumbar fusion, 35 to 80% are then found to have SI joint pain, which is the joint just below the facets, like within an inch of the facets, right? So 25 to 44% of people after facet injections said that they still had pain. Not saying that they had facet pain because the patients couldn't tell, and apparently nobody examined them, but that they had pain. At the same time, 35 to 80% of people after a fusion have pain somewhere else. This is a terrible study. So you got a questionnaire sent to people who don't do exams. You have a Pain Society consensus statement that says that they don't have enough studies to make this diagnosis or this decision anyway. And then you've got a terrible study. And from this, pain management has decided that they are the only musculoskeletal practice in medicine to not do a physical exam. So they're using MRI to create an algorithm where they use a non-diagnostic MRI, don't use a physical exam, and then use a non-diagnostic test, and they wonder why people have terrible results. And they wonder why I see, an extraordinary number of people that have never had a physical exam and have based everything, including catastrophic surgeries, on MRI, non-diagnostic tests and procedures. So their algorithm really is the myth. Because what people will do is they'll say, well, I've had facet injections. And I go, okay, but did they do an exam? No. Okay, was there anything else that hurt at the same time? And what you'll hear from pain doctors is they'll say, we treat one thing at a time so that we can stick in this algorithm, so we can stick with this algorithm. And I say, no, the algorithm is a terrible way of doing things unless there's only one problem at a time. And what pain management has shown is that one thing causes another thing. If I have facet pain, it changes the way my spine is stabilized, which can lead to a disc bulge and facet pain. If I have facet pain, it changes the way I walk, which leads to SI pain, and a change in the way my gluteus muscles are protecting both the pelvis, the hip joint, etc. I can get IT band pain. I can get piriformis muscle pain. My hip joint can start hurting. All of this can start from a single cause. And what happens is that single cause becomes multiple causes. And what the algorithm says is, no, we're trying to find the initial cause. And I say, who cares what the initial cause is? Really what you need to know is this disc and nerve pain, or is this musculoskeletal? And MRI can't tell you. So your job as a pain doctor is to say, or as a spine physician is to say, is there any musculoskeletal causes? Yes, then I have to treat those. And I have to treat them all at the same time because they're all interrelated. And that's the only way I can go, that's not what it is. It is this disc or findings on the MRI. That's the only way. Because otherwise, I'm left relying on treating one thing at a time and hoping that that one doesn't hurt way more than the other, or does hurt way more than the other. And I can actually pick that out, not by another exam, but by what the patient tells me, which is not, it's not medicine. It's not diagnostic medicine. It's not musculoskeletal medicine. It's none of that. So really what needs to happen is you go, look, I've gone thoroughly through the exam. I found all the musculoskeletal places that hurt that could be related together. I've treated those. And the person got no diagnostic relief. Therefore, I know it's the disc. Unless it's from the very beginning, you go through the exam and you go, look, I didn't find any of those, or none that were valid, none that fit with the symptoms well enough, because I went through a thorough history too, and then from that I found that the disc is the problem and it fits with their symptoms. Therefore, I'm going to treat that. Always in the back of my head, though, if that doesn't get them completely better, have I unmasked something musculoskeletal-wise, which I can only find on exam? And the problem, of course, is that pain management started from people that were doing procedures. It was anesthesiologists who were good with medications and doing epidurals for babies. And then they started saying, listen, can we do epidurals for pain, like disc bulges? And, oh, heck yeah, we can do that. Well, the people that are doing epidurals all the time are anesthesiologists. So then we took a procedural specialty where they do procedures and take care of patients before surgery, and then asked them to become experts in musculoskeletal physical exam. And instead of this musculoskeletal physical exam becoming experts at that, they said, no, physical exam doesn't work, because it kept them from having to become those people. And then they said, let's treat one thing at a time since we don't really know what it is. But first, let's treat the MRI. Even when we found out later that the MRI is not diagnostic, we're going to stick with that because we can't now switch and become experts at physical exam. So your previous diagnosis especially when you don't get better, doesn't necessarily mean that that's the problem. That's another myth. The next is that you'll hear them say we don't do steroids into facet joints, and the reason why they say that is they say because we have to have a diagnostic facet injection, and if we put steroids in there, it could ruin the diagnostic value, which is completely incorrect, right? Orthopedic surgeons, sports medicine doctors, we put injections into the wrists with steroids and lidocaine, knee, hip, shoulder, every joint in the body. Pain doctors even put steroids into the epidural space and claim that it's diagnostic. They put steroids into the SI joint. They put steroids in every joint except the facet. The problem, of course, is that what they say is the steroids don't last for 3 to 6 months, which is when they test again, 3 to 6 months. 3 to 6 months later, the steroids are not working. And if we burn the nerve, when we burn the nerve, it lasts for 6 months to 2 years. Therefore, if we put steroids in there, we're just delaying the inevitable. We got to get them to burn. We got to burn the nerve, which of course is a disaster. We don't do that with any other joint in the body. There's a shutdown of a muscle that we need in the spine that keeps us stable when we do radiofrequency ablation. And sometimes we need radiofrequency ablation, but not first line, right? So why at 3 to 6 months doesn't it work? Well, when you get a steroid shot in your knee or your hip or your elbow, it gives us 6 to 12 weeks of pain relief, of decreased inflammation, so that we can strengthen everything around it, right? Pain management doesn't see it that way. They don't do physical therapy afterwards. They do physical therapy before. So let me ask you, let's say you come in and your knee or your hip is in extraordinary pain, and they say, listen, we know your hip is inflamed, but we want you to go completely through physical therapy first. You'd get through a little bit of physical therapy. The therapist would throw up their hands and go, this is stupid. Why don't we get them out of pain so that I can really rehab their knee or their hip? And we'd say, no, this is how sports medicine does it. No, sports medicine says we made a diagnosis on a good physical exam. We then went and did a treatment. And then after the treatment, whether it's surgery or injection or whatever it is, we created a period of time that you don't hurt. We then sent you to physical therapy to fix all the problems that have occurred when you were hurt, now that you're not. Pain management says, go to physical therapy, because we really don't want to know what's wrong. 95% of the time people come in with back pain, it's muscular. So we're going to take that skewed acute pain statistic, apply it to chronic pain patients and say, we want you to go and do physical therapy because it'll wean out all the acute pain people, even though you're currently in chronic pain. We're then going to, once you've done physical therapy, we're going to do a non-diagnostic imaging. We're going to do injections one at a time, hoping to find the cause. The majority of time that this doesn't work, we either send you to surgery or do a spinal cord stimulator, but we're never going to go back to therapy because it didn't work. Well, therapy didn't work because you hurt. So another myth is that people come in and they go, I tried therapy and it was terrible. And I say, well, of course it was terrible. You did physical therapy while you hurt. What kind of disaster is that, right? The other thing they'll say, for another myth, is that people will say, well, I'm just doing core strengthening. Core strengthening is built on top of the stability of your spine. It helps, but it is not stability in your spine, right? It's like the brick outside of a house that's already been built. It's helpful. It provides stability, but it's not the core of the stability. You can't just have the bricks stacked up, right? You actually have to have a framed house. You actually have to have a foundation. So realize, and we'll get to this in the next couple podcasts, core strength adds to what's already there, but you can't just have core strength. So I'll hear people say, well, I'm just working on my core strength. Yeah, well, we'll get to that, but that's a myth. Don't just do core strength. So then the last myth, and I think I've explained these reasonably well. I think that there's a lot more with each of these that we could go into. And anybody who leaves notes or sends me a note, maybe we can figure out how to explain this more thoroughly, because I'm hopeful that this is ringing true for many a person. So the last is surgery, and a lot of people are very nervous about surgery, and they have every right to be, because everything leading that I talked about before this, can definitely lead to a person having surgery that they don't need. The thing is that there's lots of people that need surgery, and they've been frightened by all the people that had surgery that didn't need it. And really what needs to happen is that there is a understanding from my patients that I've worked really hard to get to the point where if you need surgery, it is what you need, right? So there's nothing wrong with surgery when it's the right thing. And I think it should be one of those deals where people say, the correct surgery done at the right time, followed by appropriate rehab, creates a very good outcome in people who need it. The problem, of course, is that people will have surgery. They'll be told, the disc above or below is eventually going to break down, which is, again, if rehabbed correctly and the spine is understood correctly, that doesn't necessarily happen. But they say, well, if I have surgery, I'm just going to need another surgery and another surgery and another surgery. And I think that's a flaw. So the point is that surgery is not bad when it's done in the correct timing, fashion, and sequence, right? Followed by the correct rehab. Okay, this is like I said, this is an opening go at this. I think I did a terrible job at staring at the camera again, but I'm working on it. Well, I guess we'll just have to see. So leave comments. I'd really appreciate it. Definitely need comments if I'm going to make this better. And also if you leave a review, that would be wonderful. Thank you.
Thank you for listening. We greatly appreciate your download and taking the time to listen. Please go to whatever source you normally get your podcast from and subscribe. Also, visit bodyguitar.com for show notes and to learn about our clinic. Living longer is not near as important as living better. These episodes are meant to advance the goal of living better. Until next time, body guitar practitioners, performers, and tuners, get your body in tune. This is Dr. Sean Wheeler on Spine and Body Podcast, and I will see you on the next episode.
This podcast is for general information purposes only. It does not constitute the practice of medicine, nursing, or other professional healthcare studies, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to the podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their health providers for any such condition.